Today we'll discuss the complete chemistry profile, which is basically the comprehensive metabolic panel. Comprehensive metabolic panel is a group of blood tests. They provide an overall picture of your body chemical balance and metabolism. Metabolism refers to all the physical and chemical processes in the body that uses energy. The comprehensive metabolic panel basically tests sodium, potassium, chloride, CO2, BUN, creatinine, and glucose. That's basic metabolic panel. A comprehensive metabolic panel, it marks more than the basics, and we'll discuss the extra parameters that is part of our PowerPoint presentation today. Let's start with glucose. Glucose, remember, is formed from carbohydrate digestion and conversion of glycogen to glucose by the liver. Basically, glucose is used as energy source in most organisms, humans as well as bacteria. Remember that glucose is used as part of the aerobic metabolism and respiration, as well as anaerobic. Glucose in the human body key is the source of energy. Also, remember that participates in glycolysis, so glucose is obtained by glycolysis. Basically, the reactions of the citric acid when the glucose is oxidized to form CO2 and water. This is no more than the Krebs cycle that was discussed in pathophysiology. Glucose is regulated by glucagon and insulin. Glucagon accelerates glycogen breakdown in the liver and increases blood glucose level. The use of glucose as an energy source in cells is by aerobic respirations or anaerobic respiration, as we already said. Both start with the early steps of the glycolysis metabolism pathway. The first step of this is phosphorylation of glucose. The major reason for immediate phosphorylation of glucose is to basically nourish the cell. Insulin increases cell membrane permeability to glucose and transport glucose into the cell. The insulin binds glucose receptors on the surface of the liver and basically open the channels for that glucose to enter and be converted into energy. Certain metabolites as well as hormones participates in the metabolism of glucose, and these are ACTH, which is adrenocorticotropic hormone, corticosteroids, epinephrine, thyroxine, and all the hormones of the sympathetic system. Let's talk about different etiologies that could increase glucose. And this is hyperglycemia. Well, the main cause of hyperglycemia is diabetes. Other causes of hyperglycemia would include steroids. Every time a patient is on long steroid use, glucose increases. In addition, every time our sympathetic system is stimulated or the body is under any type of stress response, glucose increases. And this is no more than due because of high release of steroids. Epinephrine, which is the hormone of the sympathetic system, also increases glucose. Amphetamines, thiazide diuretics, and of course critical illness. Every time a patient is under critical illness, there is gluconeogenesis and glucolysis. to be able to obtain glucose as a new source of energy for that cell that is either malnourished or in high catabolism due to severe illness. Causes of hypoglycemia, on the contrary, could be reactive postprandial. This means that the patient has recently eaten either breakfast, lunch, or dinner, and in less than half hour, patient is having hypoglycemia. Or just simply because the patient has had a long fasting day. Patients that administer insulin could have as a consequence hypoglycemia. Patients with tumor, such as insulinoma. Pseudohypoglycemia is also present, and this is no more a malmanagement of the laboratory sample. Factitious hypoglycemia is present when, for example, athletic or any type of person that would like to decrease weight and increases catabolism of glucose and breaks down glycogen as well with the use of or maluse of sulfonylurea or insulin. Now let's talk about sodium. Sodium is the main electrolyte in plasma extracellularly, and remember that sodium controls osmolality. This is no more than the osmotic pressure that is able to maintain homeostasis in serum. This is the cation that is 90% present in the extracellular fluid. Is the chief base of the blood. As previously stated, maintains homeostasis and osmotic pressure or osmolality. Remember that the channels for sodium open first for depolarization of any type of cell membrane. The mechanisms to maintain sodium level in plasma and extracellular fluid include renal blood flow, carbonic anhydrase enzymes activity, aldosterone, renin secretion, ADH, and vasopressin secretion. And this is important because now I will show you an algorithm that you don't need to memorize, but is to have an idea of all the causes of hypo and hypernatremia. This electrolyte imbalance will be discussed in details in your specialty courses for either family or acute care. But again, the most important factors that maintain sodium level is renal blood flow, carbonic anhydrase enzyme, aldosterone, renin, ADH, and vasopressin. Hypernatremia is basically serum sodium concentration greater than 145 milliequivalents per liter. It implies a deficit of total body water relative to total body sodium. This is caused by water intake being less than water losses. The major symptom of hypernatremia is thirst. All the clinical manifestations are primarily neurologic, and this is due to an osmotic shift of water out of the brain. Includes cell confusion, neuromuscular excitability, seizures, and even coma. Diagnosis of hypernatremia basically requires just a measurement of this electrolyte in plasma, and the treatment is usually to control the water replacement. When the response is poor, testing such as monitoring water deprivation or administration of vasopressin is all necessary. The main causes of hypernatremia reflects a deficit of total body water relative to the total body sodium content. Because total body sodium content is reflected by extracellular fluid volume status, Hyponatremia must be considered along with the status of the ECF volume. In other words, when you're going to interpret this algorithm, you need to have into account if the patient is hypovolemic, euvolemic, or hypervolemic. Note that the ECF volume is not the same as effective plasma volume. So when you're going to interpret different causes of hypernatremia, you also need to have in consideration a urine sodium level. So you do a urine spot of sodium, and if the urine sodium is elevated, that means that patient is having an excessive water intake, and this might be due to decreased ADH. And this is the actual obsessive compulsion of drinking water without thirst. And on the contrary, if the sodium is variable or the specific gravity is low and the urine osmolality is low as well, most likely the patients would have diabetes insipidus, either nephrogenic or central. On the other hand, if the urine osmolality is elevated and the urine sodium is also elevated, the most likely causes are renal losses, and this is due to diuretics. If the urine sodium is decreased, then extra renal losses are present, and this is due to dehydration. Dehydration due to sweating, diarrhea, respiratory losses, etc. Again, this is going to be discussed more in detail in your specialty areas, but this is to have a brief idea of the possible causes of hypernatremia. Hypernatremia is really rare because every time patient has hypernatremia is associated with extra cellular fluid volume status and most likely dehydration. So the patient, the most common reflex is to basically go and drink water from the refrigerator unless the patient is immobile or the patient is an elderly person who has thirst response impaired. And therefore, hypernatremia usually implies either an impaired thirst mechanism or limited access to water, and this is the reason why it's a rare etiology. More than hyponatremia. Hyponatremia is really common, and even though this algorithm seems to be very overwhelming, we're going to discuss the most common causes. The most common causes for hyponatremia are basically due by either serum osmolality. So the first parameter that we have to measure in hyponatremia is serum osmolality. So let's discuss the long algorithm first, because these two causes are very simple. So first, you need to know what is your osmolality. And remember, the values of osmolality is 280 to 290 or 280 to 300, depending on the book that you're reading. So if your osmolality is low, that means that the osmolality is less than 280. The next step is to know how's your BUN. And we'll discuss in details later on what is BUN, but remember, BUN is blood urea nitrogen. And blood urea nitrogen basically determines the volume status of the patient. So these three areas here will basically determine the volume status of the patient. If the patient is hypovolemic or dehydrated, if the patient is hypervolemic or volume overloaded, or if the patient is euvolemic, meaning normal water content in plasma. So if the patient has hyponatremia and the osmolality is low, first, is the patient euvolemic? And if the patient is euvolemic, the next parameter is to know the urine sodium content. So if the urine sodium content is high, the most common cause is that the patient would have syndrome of inappropriate antidiuretic hormone or any type of autoimmune disorder. And these autoimmune disorders would include hypothyroidism, glucocorticoid deficiency, or adrenocorticotropic stimulation test, or any type of stress that would release glucocorticoid. If, on the other hand, the patient has a urine sodium very low, that means that the urine is diluted. This patient is drinking a lot of water compulsively without being thirsty. If the patient has hypovolemia, in other words, is dehydrated, again, you measure the urine sodium. If the urine sodium is low, that means that the patient is basically not depleting sodium in urine, and means that the patient is dehydrated. Whenever you're dehydrated, you basically retain the sodium in plasma. You do not eliminate the sodium in urine. And remember, the sodium is a macromolecule, and most of the time it's eliminated through urine when you have a renal nephron damage. So if the urine sodium is low, you're dehydrated, and the most common causes of hyponatremia would be extra renal losses, which is vomiting, diarrhea, burns, and any other water shifting due to abdominal etiologies. If the urine sodium is elevated, that means that you're having most likely renal causes, losing electrolytes, and this, of course, will be the most common cause is diuretic use. Diuretic use, aldosterone deficiency, etc. Also, if the patient is hypervolemic, now what type of disease is going to give me hypervolemia and volume overload? Well, the most common causes are either you don't have any type of nephron damage, that means your kidney is intact and you're holding on the sodium in plasma. Well, you have disease process that would give you volume overload, such as CHF, cirrhosis of the liver, and nephrotic syndrome, among others that we'll discuss in your specialty areas. On the contrary, you're losing sodium in urine, that means that you have renal failure. So again, your hyponatremia, if you're hyponatremic, how's your osmolality? Is your osmolality low? Next, how's your BUN? Are you normal volemic? Are you hypervolemic? Or you're hypovolemic or dehydrated? And again, if you're dehydrated, you have to be dehydrated because either you're losing a lot of fluid through diuretics, or you're losing a lot of fluids through extra renal losses such as vomiting and diarrhea. I'm just telling you the most common causes. You're hypervolemic. Well, you're hypervolemic because you're either having a thirst-based etiology not related to kidney, CHF, cirrhosis, and nephrotic syndrome, or related to kidney renal failure. Or you're normal volemic. If you're normal volemic, that means that you have an autoimmune disorder, or you're drinking too much water compulsively. The other two most common causes of hyponatremia is when you have a normal serum osmolality, and that means that you have, in these two cases, a hyperosmotic substance in plasma that is skewing the value of osmolality. So either you have high triglycerides or you have hyperglycemia, among others, of course, that we'll study in your specialty areas. So hyponatremia, again, is decreased serum sodium concentration less than 135 milliequivalents per liter, and is caused by either an excess of water relative to solute, and the most common causes were already discussed. It reflects an excess of total body water relative to total body sodium content, the same as hypernatremia. And again, you have to basically analyze the etiologies due to osmolality. Osmolality is very important and is regulated by sodium. Potassium. Potassium is the principal cation of intracellular fluid, is more concentrated intracellularly, and is released when these cells are damaged. Just have that in mind. 80% is excreted in the urine. Average daily consumption of potassium is 80 to 200 milliequivalents per day. It facilitates nerve conduction, muscle function, acid-base imbalance, and also osmotic pressure. Not much than sodium. Sodium basically regulates osmolality more than any type of electrolyte. Remember that potassium controls rate and force of contraction of the heart and cardiac output. This is due by repolarization, and sodium and potassium ions are important in renal regulation for acid-base imbalance. So whenever you have low potassium, you have alkalosis, and when you have elevated potassium, you have acidosis. Hypokalemia is serum concentration greater than 5.5 milliequivalents per liter, resulting from excess of total body potassium stores or abnormal movement of potassium out of the cell. There are usually several simultaneous contributing factors, and we'll discuss this in detail now. Okay, I actually have better than this a chart or a bullet system for hypokalemia and hypokalemia. But have in mind that potassium deficiency causes intracellular increase of bicarbonate, and the respiratory center responds by increasing PCO2 through hypoventilation. Potassium is basically affected as well by adrenal hormones. So whenever you have adrenal insufficiency or enhancement, potassium will also vary. Hyperkalemia. The most common causes of hyperkalemia is probably pseudo-hyperkalemia, which is called by hemolysis of RBCs in the blood sample, either by a very tight tourniquet or by actually shaking the tube of the blood sample. Normal kidneys eventually excrete potassium load, so sustained non-artifactual hyperkalemia usually implies diminished renal potassium excretion. Other factors that contribute to hyperkalemia is either increased potassium intake, increased potassium release from cell, decreased potassium excretion, and renal insufficiency. If we talk about increased potassium intake, this could be due by dietary supplements of potassium, blood transfusions, when it's actually preserved in the blood bank and they have high levels of citrate, elevates the potassium. When you administer a patient either oral or IV supplements potassium due to hypokalemia, it would contribute to hyperkalemia. Any type of potassium containing drugs such as penicillin, and TPN. Increased potassium movement out of the cell is another parameter that increases hyperkalemia, and this could be beta blockers, digoxin toxicity, increased catabolism, such as patients that have cancer after chemotherapy or radiation therapy, having acute tumor lysis syndrome, or any type of intravascular hemolysis will produce hypokalemia, bleeding in the GI tract, burns, rhabdomyolysis. Insulin deficiency, such as in diabetes type 1, will produce hypokalemia. Remember that insulin brings potassium inside the cell, so if insulin is deficient, patient would have hyperkalemia. Others, extraneous exercise, metabolic acidosis, drugs that could produce decreased potassium excretion, ACE inhibitors, potassium-sparing diuretics such as aldactone, heparin, lithium. Hypoaldosteronism contributes to hyperkalemia. Remember that the function of aldosterone is to retain sodium and potassium and excrete, retention of sodium and water and excretion of potassium. So if the patient has this is a typo here. Instead of hyperaldosteronism, is hypoaldosteronism or adrenal insufficiency. So correct this. Instead of hyperaldosteronism will be hypoaldosteronism. So if the patient, remember, the function of aldosterone is to retain sodium and water and excretion of potassium. So if the aldosterone is in deficiency, patients would have hyperkalemia. And of course, renal insufficiency. On the other hand, hypokalemia is completely opposite. So if the patient have GI loss, such as diarrhea, vomiting, they would have hypokalemia. Intracellular shift of potassium inside the cell. Well, remember that insulin brings potassium inside the cell. So administration of insulin will produce hypokalemia. In addition to that, anytime a patient has an excessive beta stimulation, such as in stress, not only will release glucose, but at the same time will release insulin and to be able to break down glycogen. And due to this, potassium also is brought inside the cell and contributing to hypokalemia. Glycogenesis, hyperalimentation, any type of thyrotoxicosis, such as in hyperthyroidism, and of course renal losses. And in the renal losses would include diuretics, of course, any type of adrenal steroid excess, such as Cushing syndrome. Here is hyperaldosteronism. So if the function of aldosterone is to retain sodium and water and excretion of potassium, if you have hyperaldosteronism, you would have high increase of potassium loss or excretion. Renin secreting tumor is another etiology that could contribute to hypokalemia. Chloride goes along sodium. So whatever etiology can give you hyponatremia or hypernatremia would give you hypochlorhydria or chloridemia and hyperchloridemia. Remember, this is the anion that exists in the extracellular space, maintains cellular integrity, contributes to osmotic pressure, the same as sodium, and it's excreted in massive amounts during diuresis. So anytime you have a condition that depletes water balance, chloride goes with sodium as well. So again, all the causes discussed for hypo and hyponatremia will contribute to loss of chloride. CO2. CO2 is basically the interpretation of bicarbonate in plasma. And CO2, remember that the value is 22 to 26. So when you have less than 22 or lower than normal levels, the most common causes here would be metabolic acidosis. And metabolic acidosis, any type of disease process that will contribute to metabolic acidosis, such as salicylate toxicity, any type of poisoning, lactic acidosis, renal failure contributing to acidosis, hyperkalemia that contributes to acidosis, ketoacidosis, diarrhea, Addison's disease. When you have greater than 26, this means metabolic alkalosis or respiratory acidosis. So therefore, breathing disorders such as obstructive pulmonary diseases such as COPD and emphysema, cystic fibrosis will contribute to high levels of CO2. In addition to that, anything that contributes to metabolic alkalosis and most likely chloride responsive due to dehydration. So vomiting, diarrhea are one of the main causes for that. In addition, Cushing, hyperaldosteronism, and other disease process could be delirium, dementia, etc. Calcium. Calcium is basically stored in the skeleton and the teeth. Is 50% ionized and also highly protein bounded. So that means that your nourishment or your nutrition status is very important to be able to analyze calcium level because it's attached to albumin. Can be used by muscular contraction, is actually needed as a metabolite, cardiac function, transmission of nerve impulses, and the test measures concentration of total and ionized calcium in blood and reflects the function of parathyroid and also malignancy. Let's talk about hypercalcemia. Hypercalcemia is when the calcium concentration is greater than 10.4 milligrams per deciliter, or ionized calcium of 5.2. The principal causes of hypercalcemia would be hyperparathyroidism, vitamin D toxicity, and cancer. And the clinical features is basically polyuria, and the reason one of the main symptoms is polyuria is because calcium being deposited in the renal tubules could contribute to calcium deposits. So the kidney responds as a compensatory mechanism to increase reabsorption and urine depletion in order to clear and avoid stagnant calcium deposits and avoid nephrolithiasis. So actually our body is very smart, and one of the compensatory mechanisms will be polyuria. And that's another reason why when you have hypercalcemia, you should give a lot of IV fluids to the patient, not only to flush it out, but also to compensate the dehydration state of this polyuria. In addition, patients could have muscle weakness, confusion, and coma. Let's talk about now hypocalcemia. It's basically the opposite in symptoms. Uh, Calcium levels would be total less than 8.8 and ionized less than 4.7 milligrams per deciliter. And the causes, remember that for hypercalcemia will be hyperparathyroidism, while for hypocalcemia is hypoparathyroidism, vitamin D deficiency, and renal diseases. And the clinical symptoms basically is tetany, seizures, encephalopathy, and paresthesias. Phosphate. Let's talk about phosphate. Phosphate is 85% combined with calcium, so it's basically the opposite of calcium. Whatever causes hypercalcemia causes hypophosphatemia, and backwards. Whatever causes hypocalcemia causes hyperphosphatemia. So hyperphosphatemia is serum concentration of 4.5 milligrams per deciliter or more, and the causes are chronic kidney diseases, hypoparathyroidism. Remember that hypoparathyroidism was the cause of hypocalcemia. So they're in inverse relationship. So hyperphosphatemia with hypocalcemia and all the causes associated with that, and the same symptoms. Phosphate is required for generation of bony tissue and also participates in glucose and lipid metabolism, acid-base imbalance, and this is the reason why another cause for hyperphosphatemia is metabolic imbalances, either metabolic acidosis or respiratory acidosis. Phosphorus also enters the RBC with glucose. Um, and as I said, they have a high inverse relationship with calcium and is controlled by the PTH. Magnesium. Magnesium is concentrated in the bone, cartilage, and within the cell. Requires ADP for the actual pathway metabolism and for the production of energy. Is necessary for carbohydrate metabolism, protein synthesis, nucleic acid synthesis, and contraction of the muscle tissue. Hypermagnesemia is when the magnesium is greater than 2.1 milliequivalents per liter, and the major cause of hypermagnesemia is renal failure. Symptoms associated with hypermagnesemia are hypotension, respiratory depression, and cardiac arrest. On the contrary, hypomagnesemia is serum concentration of less than 1.4, and the causes include inadequate magnesium intake and absorption or increased excretion of hypercalcemia or the use of Lasix. Symptoms associated with it is anorexia, nausea, Trussell and Schoftig sign, hyperreflexia, tremors, fasciculations, etc. And this is because magnesium regulates neuromuscular irritability and clotting mechanisms. Deficiency of calcium is coming from the bone and could cause calcification in the aorta and other organs, contributing to atherosclerosis and CAD. Blood urea nitrogen. This is the BUN. Urea is formed in the liver along with CO2 and constitutes the final product for protein metabolism. It's excreted as dietary protein. Increased excretion is in fever, in diabetes, adrenal gland activity. Actually, blood urea nitrogen in conjunction with creatinine is the best, one of the best index for glomerular filtration rate. No BUN alone, because BUN comes from different factors. Blood, which is actually the red blood cells and all the causes associated with dehydration or heart diseases. Urea and nitrogen comes from the protein catabolism and is one of the parameters that um, reflects renal impairment and glomerular function. But creatinine and creatinine clearance are the best and most specific indicators of glomerular filtration rate and renal function. Again, creatinine is the byproduct of the breakdown of the muscle, and this is important because when the patients are in catabolic stage or elderly, creatinine could be low, although they could also be in renal failure. So it's not a very valuable number when the patients are cachectic because reflects muscle mass. Creatinine decreases as muscle function decreases as well. Decreased kidney function reduces the excretion of creatinine and is used for diagnosis of renal impairment. Now let's talk about the causes of elevation of BUN and creatinine. For example, pre-renal causes, and pre-renal is everything that contributes to the perfusion of the pre-renal arteriole, and this is no more than blood. And blood comes from the heart as stroke volume and cardiac output. So whatever disease process that impairs cardiac output and stroke volume would be the most common cause of pre-renal elevating BUN and creatinine. And this is no more than dehydration or any type of cardiac decompensation, such as cardiomyopathies, heart failure, and also increased protein catabolism and hemolysis. Intrarenal causes of elevated BUN and creatinine would be any type of renal disease, from acute glomerulonephritis to acute tubular necrosis, which is no more than a prolongation state of dehydration that damages the glomeruli. And the post-renal causes of renal failure that would elevate BUN and creatinine would be any type of obstruction. Obstruction of the ureter, obstruction of the urethra, obstruction of the calculi at the level of the bladder, cystitis, pyelonephritis, prostatitis, etc., as well as tumors. Osmolality, we discussed already osmolality when we talk about sodium imbalance. Remember that measures the number of dissolved solute particles in solution and is a measurement of homeostasis. Increases in dehydration and decreases in fluid overload. Evaluates water and electrolyte balances, and also assess different other functions such as liver disease, ADH, and is also elevated when the patients have intoxication such as in ethanol or ethylene glycol. Other parameters discussed in comprehensive metabolic panels are amylase and lipase. Remember that amylase is an enzyme that changes starch to sugar, is non-specific for an organ because it's present in salivary gland, in the liver, in the duodenum, in the fallopian tubes, as well as the pancreas. On the contrary, lipase changes fat to fatty acids and glycerol and is the most specific enzyme for pancreatitis because it's the major source of the pancreas. Bilirubin, when we talk about hemogram or CBC, we discuss the different causes of RBC breakdown. We discuss the causes of prehepatic. So the causes for prehepatic bilirubinemia or unconjugated bilirubin or indirect bilirubinemia, remember, is the breakdown of the RBC, and this is due by hemolysis. The liver causes or intrahepatic is any disease process that is located in the liver, such as hepatitis or hepatocellular carcinoma. And because the gallbladder is directly attached to the liver, the posterior wall, any disease process that affects the gallbladder, such as cholelithiasis or cholecystitis, also produces intrahepatic hyperbilirubinemia. Now, if you remember the anatomy, whatever is connected to the liver and the gallbladder, such as the common bile duct in cholangitis, or the duodenum, duodenitis, or the pancreas, pancreatitis, will produce the posthepatic causes of hyperbilirubinemia. And this would give you the intrahepatic, and the posthepatics will give you an elevation of direct bilirubin or conjugated. Uric acid is formed from the breakdown of nucleic acid, is the end byproduct of the purine metabolism. And remember, any type of overproduction occurs due to excessive cell breakdown and catabolism of nucleic acid. And this is highly prevalent for gout, renal failure, post-renal, and leukemia. Thank you for your attendance.